Hello, so I am going to talk about anticipation in C9orf72 repeat expansions. First of all, I'd like to tell you for what it stands, C9orf72. C9orf72 stands for chromosome 9 open reading frame 72, which is a regulatory region that is located on chromosome 9. And this region exists of a repeat of 6 nucleotides. And normally you have about 2 till 24 repeats. But in 2011, it was discovered by us and by other research groups that an expansion of this repeat can cause frontotemporal lobar degeneration and ALS. Frontotemporal lobar degeneration is a form of dementia in which behavioral problems and or language problems are the most prominent features. And the pathogenic repeat, the cutoff for that pathogenic repeat is about 60 repeat units, but it is not clearly known what is the lowest pathogenic repeat. And there have been seen repeats up to 4,000 units. It is a major cause of familial FTD and ALS in our Belgian cohorts. And for example, in patients that have FTD and ALS, up to 80% of them, of the patients that are familial, are explained by the C9orf72 repeat expansion. Then how do we detect the repeat expansion? Standardly, the test has been done by repeat primed PCR assay. With this assay, we can detect expansion alleles of more than 60 repeat units, but we cannot determine how long the exact number of the repeats is. If we want to know how long the repeat is, then we can make use of southern blot hybridization analysis. With this, you can only make an estimate of the number of the repeat units because of somatic mosaicism that hinders accurate sizing of the repeat. And also you have need for a high amount of high quality DNA, specific expertise and specific equipment that is not always there in all diagnostic labs. To determine the normal repeat alleles, we use a PCR repeat assay. And we have observed that repeat alleles between 7 and 24 repeats have an increased risk for repeat expansion. So I told before that the cutoff that has been used by most authors for pathogenic repeats is about 60 units, but observations that we have done suggested that a shorter repeat might also be pathogenic. And so we designed an optimized short expansion PCR assay. With this, you can detect the exact length of alleles with an approximate upper limit of 80 units. So only repeats of less than 80 units are detected with this assay. And we observed that in about 5% of our repeat expansion carriers, there was a pathogenic short repeat between 45 and 78 units. As you can see here in the figure, ooh, sorry. Okay, here we are again. As you can see here in the figure below, so the lower strong bands indicate the wild type allele, and then here, if you can see this, there is a more weaker upper band, and that represents the short pathogenic allele. Then I come to the term anticipation. So anticipation, what is that? Anticipation is something that occurs quite frequently in repeat expansions. It is an increase of the repeat expansion signs between subsequent generations. And it is because you can see that the repeat expansion can be seen as a dynamic mutation which is at risk for faults in the polymerization, the replication of the DNA. And we have shown in one of our families that a parent had a short repeat of 56 units. It was someone who had proven FTD on autopsy, and his child had a long repeat expansion of more than 1,000 units. Furthermore, we have also observed correlation between repeat expansion size, onset age, and degree of methylation. Methylation is a regulatory mechanism which if you have methylation, there is silencing of the gene. And so we saw a significant younger onset age in carriers with a long expansion. So then I come to my work, the clinical evidence for genetic anticipation. To study this, we have collected and reviewed clinical data of about 31 C9orf72 pedigrees, and we saw there a mean onset age of about 56 years of age, with a high variability ranged between 29 and 75 years of age. As you can see, we showed a significant younger onset age in the youngest generation than in the second generation, and that is what we expect in anticipation. You can see here on the graph, the blue line indicates the third generation or the youngest generation. The green line indicates the second generation, so the older generation, and then the orange line represents the oldest generation. As you can see clearly is that at a certain age, a higher proportion of the youngest generation is affected in comparison with the older generation. You do not see this clearly between the first, so the oldest generation, and the second generation, and this is mainly because we did not have sufficient onset ages of the oldest generation. You have to know that for the onset ages, we have to rely mostly on what family members say, and it's not always easy for them to say when the first symptoms began, especially not in the oldest generations. So in the previous slide, we made use of a comparison between two generations, independent if it was a parent with a child or his uncle with a nephew. But here we've done an even more interesting approach, where we have looked specifically at the parent with their offspring. And we had onset ages of 22 parent-offspring pairs, which are all illustrated here, and so the black patients are patients with FTD, the light gray ones are patients with ALS, and then the darker gray, like here, are patients with FTD and ALS, and then the ages are also, the upper age is the age at onset, and the lower age is the age at death, or when they're still alive, the age of the last evaluation. And so we compared them, and we saw again a significant younger onset age in the second generation, and there was a mean difference in onset age of 7 years of age. And then you can see here in the graph, so the red dot is the age of onset in the first generation, so the oldest generation, and then the blue dot is the age at onset of the second generation or the youngest generation. And so what you expect is that the red dots are above or on top, and the blue dots are below. As you can see, some parent-child pairs have a reverse pattern, but you can see that these differences are rather small, and as we said, it's not always easy to estimate the onset age, so it could be that there were some wrong estimates of this. What we have also seen in other repeat expansion diseases is that you expect with anticipation more severe disease. So more severe disease mostly means a shorter disease duration. So we have also looked at if there was a difference between the disease duration of the patients of the first generation with the second generation, but we could not observe a significant difference. But with this we have to make the comment that ALS patients are known to have a significantly shorter disease duration than patients with FTD. In our cohorts, for example, patients with FTD have a double disease duration than patients with ALS. And so it was interesting to look if how the patterns were. Was it always a parent with FTD and a child with FTD? Or was it sometimes another pattern? And so we looked at this, and we saw that in the majority of cases there was no change of phenotype between parent and child, but in 1/3 there was a change of phenotype. So this could be the parent had FTD, the child had ALS, or the father had ALS, the child had FTD, or FTD with ALS. As you can see here below in the table, there's no clear pattern, and all kinds of patterns were there. And furthermore, since we expect a more severe disease in the second generation, we looked if we saw more ALS in the second generation, because you can see ALS has a more severe phenotype than FTD, but also here we could not find any conclusive results. So then I come to my conclusions. So we have showed genetic and clinical evidence of anticipation in C9orf72 repeat expansion carriers. What does this mean for the clinical practice? When, first of all, you can expect anticipation in C9orf72 repeat expansion carriers, which means that you can expect that there can be an earlier onset age and maybe also a bursar disease in the second generation, in the youngest generation. Furthermore, for the genetic diagnostics, it could be interesting to implement the short expansion PCR assay in addition to the standard repeat prime PCR assay as a fast and reliable screening method for identifying expansions up to about 80 units. And then we have some suggestions for future research. We have to look further if we can detect an increase of severity with increase of repeat expansion size, and for this we will need a larger population. But of course we have to wait till people get sick for that. And then we also want to look if there is an influence of paternal or maternal transmission of the disease allele. For example, in Huntington's disease, that's another repeat expansion disease. You see that there is a higher chance of anticipation when there is a paternal transmission. For example, in myotonic dystrophy, another repeat expansion disease, there is a higher risk of anticipation when there is a maternal transmission. And then furthermore, we want to look if there are specific clinical characteristics for the patients with short pathogenic repeat expansion versus patients with long repeat expansions. Okay, this was my talk. I'd like to thank all my colleagues, and especially Ilse Gijsling, who has done the genetic analysis. And then furthermore, I'd like to thank neurologists of the patients, and of course all the participants, the patients and the families. And I'd like to thank you for your attention, and I'm willing to answer your questions.
Okay, thank you. Are there questions?
Okay, I was wondering what you call generation 1 or your oldest patients.
Yeah.
That's of course not generation 1 because probably their parents
Yeah,
also were carriers. Is this then a new disease, or do you expect that the age of onset will, the next generations really decrease to very young age?
Yes.
Or why did this not happen in the past?
Well, no, it's just because we don't have information of the we can only, from now, we ask or we get clinical information from, or clinical data from doctors, neurologists, and we just don't have information of the older generations. That's also why you see that in the graph with the 3 generations, the oldest generation, we could not make any conclusive results, but we only had ages at onset of 6 patients or so. But you expect that in further generations that there would be a further anticipation.
But if this is really the mechanism, is it then a new disease? Because otherwise I would expect that the age of onset would be maybe 20 years. Because why if you say that there is 7 years of change in age of onset, okay, and I don't know which age you were now, but why is the age of onset, even of these 6 patients that you have, so high? Because their parents was also a generation with the mutation.
Yeah, of course you don't have always an anticipation. Anticipation can be there, and also we expect it more in patients with a short repeat. So if you have repeats of about 50 units, we have seen that they have the chance to become at once very big in the next generation. So probably these patients of 56 are the first or one of the first generations with the disease. But when you reach larger expansions, you can expect that there would be a kind of plateau, so no anticipation anymore, or not that amount that is that big. I hope this is kind of what you mean. Okay.
Okay, other questions? Okay, thank you. So